I'd like to welcome everybody. Glad everybody could join us tonight. Welcome to the August meeting of our nonprofit plant-based nutrition organization of Wisconsin, or as we like to call ourselves, PB Now. I'm your host, Terry Lynch, and the mission of our nonprofit group is to educate, inspire, and support each other on an evidence-backed, whole plant food-based nutritional path for health and improved quality of life. Our group is open to everyone, those plant-based and those just curious about it. And if you'd like more information about our group or our upcoming meeting dates, speakers, and resources, or just to check out videos of our past meetings, you can just Google us at pbnow.org. That's pbnow.org, not .com. As we do each time, can I see a show of hands, either by raising your hand if you're on video, or using the thumbs up icon on the bottom of your Zoom screen to show how many of you are currently following a plant-based lifestyle. We see things popping up. Oh, I see Tom there. Yeah, that looks great. That's about I'd say a quarter. I mean, 3/5. I'm trying to think. 2/5. As we mentioned at the beginning of each meeting, the evidence of the benefits of plant-based nutrition in improving health and quality of life for people of all ages, as published in non-biased medical research, is quite striking. Whether it's improving health through increased energy, weight loss, preventing, slowing, stopping, or reversing problems like allergies, digestive problems, diabetes, heart disease, and early dementia, or increasing our quality of life by just helping us feel better quickly, strengthening our immune system, increasing our endurance, improving athletic performance, recovery from exercise, reducing joint pain, and the physical, emotional, and financial side effects of the illnesses, drugs, and procedures often recommended to treat the conditions that plant-based nutrition can help us avoid. The research shows that our bodies do a wonderful job of healing themselves if we stop damaging them daily with poor nutrition and start giving them the nutrition they need to heal and function optimally, and to give us a chance to enjoy each day of our lives. It's truly remarkable. Now, let me tell you what's in store for you tonight. Tonight, we'll hear from two speakers. Our first speaker will be our PB Now Medical Director, cardiologist, Dr. Josh Liberman, with some comments. And following Dr. Liberman will be our featured speaker, Dr. Ted Barnett, to talk to us about how to successfully begin a whole food plant-based lifestyle. We should have time to ask Dr. Barnett questions at the end of his talk. Tonight's program should end about 7:30 p.m. And as a reminder, we have meetings every month, usually on the second Thursday of the month at 6 o'clock Central Time. Next month, on September 14th, our featured speaker will be our own PB Now Medical Director, Dr. Josh Liberman. We'll post more information about our next meeting and our upcoming meetings on our website at pbnow.org. A note on one of our upcoming speakers, Esselstyn Tierney, who some of you may remember, has spoken to the group before, and she'll be speaking to us this January. She'll also be a speaker at the annual upcoming Plant-Based Prevention of Disease, or PPOD, conference in late September. And I'll try to leave a link in the chat box for those of you who might have an interest in learning about the conference. It's open to physicians and healthcare professionals who can earn continuing education credit if they attend in person, and it's also open to the public. Quick technical note: during the meeting, everyone but the speakers will be muted, and we ask you to stay that way to avoid background noise and allow everyone to hear the speakers. All right, here we go. Our first speaker tonight is a fellowship-trained cardiologist. He is president and CEO of Wisconsin Cardiology Associates. He's past president and current trustee of the Wisconsin chapter of the American College of Cardiology. He's a member of the American College of Cardiology's National Nutrition and Lifestyle Work Group, whose membership includes nationally known physicians such as Dr. Dean Ornish, Dr. Caldwell Esselstyn, and Dr. Neil Barnett. He's an advocate for the use of plant-based nutrition to help improve heart health, general health, and quality of life, and has seen the benefits of plant-based nutrition in both his personal life and that of his patients. We're fortunate to have him here in Milwaukee as our PBNL and as our PBNL medical director. I'm happy to welcome Dr. Josh Liberman. Dr. Liberman?
Thanks, Terry. Thanks as always. Hope everybody is doing well out there in Zoom land. Unfortunately, it seems like summer's coming to a close, so please get out and enjoy as much as you can and soak up the vitamin D as you can, since just a couple months from now, we unfortunately are probably going to all be shut-ins. Unless I guess global warming continues and it's going to be this hot, this temperature in December, January as well, I suppose. Thanks for sharing some of your time with us as usual. For those of you, I think most of the people have been on these calls before. So those of you who know that I like to talk about the research, as Terry says, we try to be as evidence-based, evidence-backed as we can. And this is not talking about voodoo properties of some, strange supplement that only one person sells or anything like that. We really try to show that this is completely within the realm of human experience with observational studies, clinical trials, everything. Really shows us that eating a plant-based diet certainly promotes better health. Usually, I tend to talk about a recent study that came out talking about the benefits of plant-based eating. Today, I'm going to talk about two slightly different things, just because honestly, it piqued my interest, not so much specifically referring to plant-based eating, but I think it refers to healthier living in general. One of the things I wanted to talk about was an interesting study that I saw that came through actually just yesterday in one of the journals that the cardiology community reads, called Circulation. And this article was intriguing to me, and really what it was looking at specific bacteria in the gut and their link to plaque buildup in the heart. Now, many of you on this call probably are aware, because we've talked about in the past, both from guest speakers as well as myself, as well as it's just been in the news, that there's an increasing interest in scientific research and in the scientific community about the relationship of gut health to overall health, right? So your intestinal health, your stomach health, to your overall health, but of course, in my world, specifically heart health. And we do know that there's a lot of research linking better diets with bacteria that are thought to be favorable for overall health. And we know that there's components of unhealthy diets, such as red meat, that increase unhealthy bacteria in the gut. And of course, the purported link is then to explain, increased risk of heart attack and stroke. So we don't actually have strong evidence done in large trials, certainly not in randomized controlled trials. It'd be really hard to do that show that eating red meat changes the gut bacteria to a certain bacteria, and that's the reason that you have increased heart attack. But what this study looked at was trying to see if there are certain bacterial species that are more associated with heart plaque, and the answer is there are some. And again, this is not specifically talking about diets or plant-based diets or anything like that, but it specifically was looking at patients with heart disease, hardening of the arteries, identified mostly by coronary artery calcification. And so they looked at a population of almost 9,000 people in Sweden. Average age was about 57 years old. And what they found was that there were very, very strong associations with some of the bacteria that are normally found in the mouth, Streptococcus species. So not like, technically the same species as causes like strep throat and strep pneumonia and things like that. But they were able to see that these specific strains of bacteria in the gut were much more prevalent, were much more out of proportion than would be expected in patients with heart disease. And so, of course, this study is just showing further evidence of an association between the bacteria in our gut and different health markers, including atherosclerosis. So it shouldn't be that much of a stretch to say then that by reformulating or repopulating the bacteria in our gut with healthier bacteria could then lead to lower rates of heart disease, certainly lower rates of illness. And so that's where we do certainly believe that plant-based eating can certainly help with that, because the amount of fiber in plant-based diets certainly promotes, what we think to be healthy bacteria in the gut. So that was just one study. As I said, it's nice to see it in a cardiology journal that we're starting to try to look beyond just the routine risk factors of cholesterol, of blood pressure, of sugars, and things like that, and to look to see if there are other things associated with the development of heart disease. And hopefully over time, we can take the next step to show that, eating a specific diet, likely a plant-based diet, can then lead to better populations of bacteria in the gut, which then directly leads to lower risk of heart attack. And that would be yet another mechanistic link that explains the strong benefit of plant-based eating. So that actually just came out yesterday, actually. So I wanted to talk about it today. Other thing that I thought would be worth talking about was something that's been in the news quite a bit lately, which is this concept of inflammation and how inflammation affects the heart, right? So how did this get into the news? Well, the FDA just announced that they were giving approval to a new medication. Well, I shouldn't say a new medication, they were giving a new indication to an old medication, an old anti-inflammatory medication, and the indication was that it was effective. It was proven to be effective at lowering the risk of heart attack and heart disease. Okay, so what am I talking about? So there's a medicine that is really ancient. There's evidence that it's been used as early as Egyptian and Greek times, thousands and thousands of years ago. Okay, it's a medicine called colchicine. I don't know if anybody was reading the news or saw this in news reports, but there's a medicine called colchicine, which, as I say, it comes from a plant, like a weed, a flowering plant that's known to be toxic, actually, called the autumn crocus or naked ladies. I don't know if we have any botanists in this group, but it's been used, as I said, since ancient times in Egypt and Greece to treat things like joint swelling and whatnot. And it's actually been approved for use as an anti-inflammatory in the US since 1961. So this is not a new medication. In fact, in recent years, the cardiology world has been using it a lot more because it's been a very effective treatment for something called pericarditis, which is an inflammation of the bag that holds the heart. So the heart sits in the chest, but it kind of sits in this bag called the pericardium. And you can get inflammation of that bag, of the pericardium, and that's pretty painful. And colchicine has been shown over the last 10 years to be extremely effective at reducing the inflammation and also preventing it from coming back. So we've been using this medicine. It's typically dosed at 0.6 milligrams twice a day. Okay, so what's new? Well, about 8 to 10 years ago, some researchers started looking at it to see if it could also reduce the risk of heart attack, because we know that elevated levels of inflammation increase risk of heart attack. You say, well, what do you mean inflammation, doc? Okay, anything that causes chronic inflammation. So if you have arthritis, really bad knee arthritis, for example, or if you have rheumatoid arthritis, which is an autoimmune disease, or any other autoimmune disease, or if you have periodontal disease, or if you had a cold, all these things will raise the level of inflammation in your body, and we can identify that raised level of inflammation through different blood tests, looking for different proteins in the bloodstream that are elevated when you have inflammation. One of those is called CRP, which stands for C-reactive protein. Really, it's just a marker. It's just a flag saying, pay attention, there's inflammation going on. It's not actually causing inflammation. It's just a marker. It's just a flag, okay? But we know that people who chronically have elevated levels of this CRP protein have increased risk of heart attack. So you don't get that just from having a cold, right? A cold is just transient. You have a cold, you have higher inflammation while you have the cold, and then it goes away. A a flare of arthritis in your knee, similarly, isn't necessarily going to cause chronic inflammation. But other problems like periodontal disease, like autoimmune disease, all these, other things, being overweight, eating a poor diet, all of these things, being diabetic, all of these things can raise your level of chronic inflammation. And we know that chronic inflammation is linked to heart attack risk. So it makes sense that doctors would start researching to see if anti-inflammatory medicines can lower the risk of heart attack. They certainly lower the risk of this protein, but can they lower the risk of heart attack? And sure enough, that's exactly what they found. So a couple of years ago, in November of 2020, right? So this is kind of in the teeth of COVID. There was a trial called that looked at low dose colchicine, a very low dose of this medicine. As I told you, the typical dose is 0.6 milligrams twice a day. They were looking at 0.5 milligrams once a day. And you say, well, why 0.5 versus 0.6? I think there's a reason for that. We'll get to that. But bottom line is they were looking at a low dose of this medicine to see if they could reduce the risk of heart attack. So they took 5,000 people, they took half of them and they put on this low dose of medicine. They took half and they gave them, placebo. And sure enough, at the end of the trial, there was a 30% reduction in the risk of heart attacks and major cardiac events, right? So does that mean that we all should run out and go on this medicine immediately? No. First of all, the study really looked at only people who already had heart disease and specifically had a lot of heart disease. So they either had heart catheterizations that showed blockages, or they had a calcium score. And many of the people on this call have heard me talk about calcium scores in the past, but a calcium score greater than 400, which is a pretty high score. So in order to get into the trial, you already had to have heart disease. So right away, we know that this doesn't apply to everybody. And the question, of course, becomes, does it apply to people who are eating plant-based diets? Does it apply to people who have low levels of inflammation? Because we also know that plant-based diets lower inflammation in the bloodstream. There are links to plant-based diets and lower levels of this CRP. And certainly from my own personal experience with taking care of patients over the last 15 years, patients who are eating vegan or predominantly plant-based diets almost uniformly have very, very low levels and ideal levels of this CRP test. So the question becomes, is this medicine beneficial for patients who normally have low levels of inflammation? It's unanswerable right now because to get into this trial, they did not check for levels of inflammation, which I think is unfortunate, to be honest. I think it would have taught us a lot more, but they did not check for levels of inflammation. They did not publish any of that data. And so we don't know if the effect is stronger in people with higher inflammation and weaker or non-existent in people with lower inflammation. So I think the jury is still out. I don't know if anybody has heard these news reports about this medication. I alluded to, I think it's a little bit, I think maybe sinister is too strong a word, but they specifically created a new dose that hasn't been used before, that 0.5 milligram dose. I told you for decades we've been using 0.6. There's no evidence that we don't have a lot of mechanistic reason to think that 0.5 would be beneficial and 0.6 would not be. Of course, why did they do 0.5? Because they now have a patent on the 0.5 milligram dose. They have an indication, and that means they can charge a lot of money for this, for this new dose, even though the medicine is thousands of years old. So again, a little devious, a little sinister, but I guess that's what big pharma is all about these days. So
Too quick.
Go ahead.
Got a couple questions here already. Is there from Michael? Is there a slower rate of cardiovascular disease development or CACS scores or related outcomes in patients like rheumatoid patients who had been chronically taking colchicine?
Yeah. No, I can see it, Terry. I'll take over from here. Sorry, not to make you struggle through that. No, brilliant question. Exactly the right question. You would like to see that people who are chronically on this medicine would have lower rates of heart attacks. That would be a great observational trial. The problem is that historically, there aren't a lot of people who take colchicine daily, for months and years. Usually we use it for very short, finite amounts of time, because in the higher dose, it can cause diarrhea over the long term. It can cause some other side effects over the long term. It can cause some kidney issues. So classically, we use colchicine to treat gout for, we'll give somebody a week or 2 weeks of it. For pericarditis, we'll give somebody 3 months of it. But there aren't a lot of people who are on it daily for months and years. And so that was one of the innovations in the last couple of years that has come out of these trials. You're speaking exactly like a researcher should think, to say, well, what do we have evidence of, in other lanes? That said, to be honest, we don't need a lot of confirmatory evidence. It's not just this one trial. There was another trial called the Colcott trial, I believe. Wait, let me look it up real quick. Colcott trial, which was published in 2019, that showed that when they put people on colchicine, again, low dose, right after a heart attack, repeat heart attacks were a lot lower than in groups that received placebo. So we do have a fair amount of confirmatory evidence that going on this medicine will lower your risk of heart attack if you are a high-risk patient. What does that mean? If you've had a heart attack recently, or if you have a significant burden of plaque in your heart. As I said, what we don't know is if you have no plaque in your heart, and we don't know if you have low inflammation in general, and we don't know if you're eating a healthy diet that lowers your inflammation. We don't know if there would be benefit in those groups. So for the purpose of this group that we're talking today, most of the people in this group are eating a healthier diet, I would say, than the general American population. And so I don't know if this research is applicable to us, but it is certainly intriguing, and hopefully we will learn more and more over time. Certainly, the most natural way to lower inflammation is to eat a healthy plant-based diet, to exercise regularly, and to get a good night's sleep. And if you can do those 3 things, you can probably save yourself the thousands of dollars a year that you have to spend on this medication that's been out for thousands of years.
I think there was another question in there too.
Michael, you're in the know on this stuff. Yes, methotrexate was looked at, and so I was actually one of the investigators in a trial. It was about 6 years ago. There was a trial called the CIRT trial that when I was at Ascension, we were one of the sites that participated in this trial. It was an NIH-run trial. It stood for Cardiac Inflammation Reduction Trial. And what we looked at was low-dose methotrexate. So methotrexate is a very powerful anti-inflammatory medicine that is used for, again, some chronic inflammatory conditions like rheumatoid arthritis. It's actually used in some cancer treatments as well. And so what we looked at was a very, very low dose on a chronic basis of methotrexate. And unfortunately, it did not show a benefit in heart attack reduction. And so the trial was actually stopped early. Now, maybe it was a problem with the dosing regimen. Maybe it was, there's other things. Methotrexate has, some other effects. It's not as clean a medicine. And so that did not put an end to the anti-inflammatory approach to treating hearts. But it certainly was a disappointment. And as I said, I was part of that trial.
There was a question about the spelling of
colchicine. Yeah, so it's in the chat. If you just look above it, Michael Silver has the exact perfect spelling of it right there. The medicine is going to be called Lodoco, Lodoco, for low dose colchicine. Lodoco. They're not very innovative, I would say. But when it comes to some of these other crazy names of drugs you hear about, maybe it actually does make the most sense on the other hand.
It's kind of a fun name, actually.
Yeah, actually, something. Now that I'm saying it out loud, I agree. At least there seems to be some relationship, and it is a little bit fun. So I'll give them credit for that one, actually.
Any patient stories this week or this month?
Yeah, I've been doing a lot of lectures actually this week. I was in Stevens Point at a conference yesterday talking about benefits of lifestyle medicine, basically. And so my part was talking about the effect of healthy nutrition on the heart. Because I've been out of the office a fair bit this week, I don't have any patient stories off the tip of my tongue, but I will say it was really invigorating to be able to travel to different parts of the state that you wouldn't necessarily. I mean, I'm not trying to cast shade on Stevens Point, but you wouldn't necessarily think of a place in central Wisconsin as being really interested in healthy lifestyles and focusing on using healthy lifestyles as a means to get to reduce poor health outcomes. But it was a well-run conference. It was really interesting, and there were some representatives from employers that actually self-insure, so they're looking for ways to keep their employees healthy to ultimately lower their healthcare costs. There were some representatives from insurance companies as well there. So I think that, again, I've said this a couple times, but each day, each week, each month, I do feel like the tide is turning a little bit, that focusing on healthy lifestyles as a means to improve health, which, I mean, it sounds crazy when you say it out loud that should be a thing. I mean, of course, healthy lifestyles should lead to better health. But it's really increasing in prominence, and it's getting to places you wouldn't expect it. So
That's excellent to hear. I've got to thank, I mean, already in your practice as compared to your cardiology colleagues, that you have the opportunity to possibly see more people getting better.
no question. Yeah, no question. We've had, we've seen, so last week we actually had two patients that showed significant improvement in their heart disease burden when we had to look back at either calcium scores or other methods that had been doing the diet for a while. And so we were able to, it proved the principle, so you have, there was a guy actually, so thanks for reminding me, there was a guy that had a calcium score. I don't know, I don't have his chart in front of me, so bear with me. It was about 2008 or so. And it was minimally positive, not bad. Had another one in 2018, so like 10 years later, and it had gone up significantly higher, and he hadn't been doing anything really in the meantime. He met me in 2018, talked about a plant-based diet. He's been exclusively plant-based since that time. And sure enough, when we checked his calcium scan pretty recently, because it was 5 years, and we were curious, we wanted to see, his number actually went down. Which was an amazing thing. And so he's had perfect numbers for a very long time now. And so that just showed how powerful this can be. And certainly it was reinforcing that 5 years of, you could call it hard work. It's not really hard work, but 5 years of making significant lifestyle change compared to how he had been in the past has really paid off.
And I think there was something else popped into the chat here. Donna said, how often should I have a calcium cardiac scan?
Yeah, I mean, I think I typically recommend repeating it on the order of 4 to 5 years later. That said, if you haven't changed anything, right? If you haven't changed the way you were eating in the last 5 years, since in the time that you had that last calcium score, if you haven't gone on medication, if you haven't done anything, I don't know if there's a point in getting another one. You can. The number's going to be higher. I mean, that's just what happens. If you have made significant changes, and if you have gone on medicine or both, then yes, 5 years later, I think would be a very good time to get it, to check on whether what you're doing is working. And if it's not working, if your percentile rank is still going up, not so much the score, because the score can go up for lots of reasons, but if your percentile rank is not dropping, right, which means that you compared to your peers and what would be average for your age, for example, if you're not making progress there, then you need more intensive therapy one way or another, either more intensive diet change, or more exercise, or reducing inflammation, or medication. So yeah, I think it's a useful tool in the 4 to 5 years later range. Was that patient on Crestor or something like it? Yeah, the patient who had the increase in score from 2008 to 2018, he had actually been on a low dose statin, I think, for most of that time anyway, but his score went up. substantially. And so the major change we did was the diet, but he's been on medicine. What is the statistics on missing soft plaque and a negative? Yeah, I mean, it depends on age. So this is Malini Mehta asked, what are the statistics on missing soft plaque with a negative CT calcium score? Absolutely. If you check a calcium score at age 40 and it's 0, that is not carte blanche to start eating, Big Macs every day, and you don't have to worry about anything, because at that age, 35, 37, 40, 45, it's likely that you have a lot of soft plaque and not at all hardened. If you get to age 60, 65, and 70 with a 0 score, it's hard to believe you have any soft plaque. For you to have a load of soft plaque at age 65 and not one speck of it has calcified, not one speck is hardened, is really stretching the imagination a little bit. So depends on the age. We know that our heart scans do not catch soft plaque, but it really depends on the age for what that means.
Well, Dr. Lieberman, thank you very much for the time you've spent in those 2 interesting studies and answering all those questions. That's outstanding. Thanks. And we will now go to our featured speaker tonight, who's been called the...
I want to hear more from Dr. Lieberman.
Pardon me?
I want to hear more from Dr. Lieberman. He's much more interesting than I'm going to be.
Well, you can tune in next month.
I doubt that.
Right.
Our featured speaker tonight has been called the high-tech doctor with low-tech solutions. He's a graduate of Yale University with an MD from Tufts. He is board certified in diagnostic radiology and vascular interventional radiology, which he's practiced in the Rochester, New York area for over 35 years now. He is also board certified in the new and rapidly growing medical discipline of lifestyle medicine that actually Dr. Lieberman was just talking about, and has served on the American College of Lifestyle Medicine board. He, his wife, and 3 children have thrived on an exclusively plant-based diet since 1991. And he'll talk to us about how to successfully begin and maintain a whole food plant-based lifestyle, and specifically about a monthly Zoom program that's reached over 2,000 people in 44 states and 7 countries. He's coming to us tonight from the annual International Conference on Nutrition and Medicine that he's attending in Washington, D.C., and I'm excited to welcome our featured speaker tonight, Dr. Ted Barnett. Dr. Barnett?
No, thanks. It's great to be here. Yeah, I have to have my virtual background on because I'm in a hotel room right now. So, and I did not make the bed. So anyway, great. Well, you've already given me the introduction, so I will move on from my title slide here. And thank you again for inviting me. And so Rochester Lifestyle Medicine Institute has a wellness wheel that's based in part on the American College of Lifestyle Medicine, 6 pillars of wellness, which are, if you start in the upper right-hand corner, plant-based diet. You guys not working there. And there it is. Plant-based diet is kind of the main one that we focus on, but the next 6 are all, or 5 are all very important. So physical activity, avoiding toxins, getting restful sleep, managing stress, and fostering healthy relationships. And then we've added 3 more of our own: enjoying nature, finding purpose, and finding joy. And interestingly enough, there's a movement at the American College of Lifestyle Medicine to add enjoying nature as a 7th pillar. So we came out with this 5 years ago. And so they may be catching up to us. We'll see. Anyway, our organization receives financial support. And by the way, we are a nonprofit. We get financial support from the Ardmore Institute of Health in Ardmore, Oklahoma, Accountable Health Partners, which is an ACO in Rochester, New York. Physicians Committee for Responsible Medicine has sponsored us. University of Rochester Medical Center, the Department of Nephrology. We just completed a randomized controlled trial utilizing our program. Nutrition Facts, Dr. Michael Greger, who I'm sure a lot of you are familiar with. The T. Colin Campbell Center for Nutrition Studies. Veg Fund, which is a national advocacy organization, and very generous donors. And shameless plug, ask how you can join the cause if you are interested in supporting our work. My wife and I are full-time volunteers for RLMI. I still work as a radiologist, and that's how I earn my living. But we do have 7 full-time paid employees, and we do have to pay our employees, and we have 10 part-time paid employees. So you can do the math. We have a fairly high budget for an organization that I kind of started by accident. I will tell you more about that later. Well, the way we think of ourselves is we feel like we are operationalizing plant-based nutrition in a broken healthcare system. I'm sure you've heard from many, many people about just how broken the system really is. And let's see, get my mouse to work here. I always have trouble with Zoom. Let's see, let's get this over here. So Jumpstart is simple for doctors to order. We try to make it a low barrier to entry, and the program, Jumpstart program, easily scales and reaches everywhere in the world, really. We're working to change the healthcare system, save human and animal lives, and heal the planet, all at the same time. Right now, as Terry mentioned, I'm at the International Conference on Nutrition and Medicine in Washington, D.C., and that's Dr. Neil Barnett there on the left, and I'm adoring fan there. I don't know how many people here are familiar with the work of Physicians Committee for Responsible Medicine, but they are huge in the plant-based nutrition world and lifestyle medicine world. Here's Dr. Neil Barnett at our table. We have a table at this this particular conference, and you can see right behind me is our banner, Ask Your Doctor If Eating a Healthy Diet is Right for You, a little spoof on drug ads. And that's Deborah Chiali, who is on our staff. Actually, she'll be receiving an award tomorrow night at the awards dinner for the International Conference on Nutrition and Medicine. As a nurse practitioner, she's been an absolute pioneer. I'm proud to say that she is on our team. Anybody recognize who that is? Okay, go ahead, Terry. Who's that?
Me unmute you, Brenda Davis.
Yeah, exactly. It's Brenda Davis today at the conference. We've known each other for decades. So our kids kind of grew up together. Good job. Okay. So who am I? I'm the high-tech doctor with low-tech solutions. What does that mean? Well, that's one of my high-tech solutions or high-tech treatments. That's an angioplasty balloon. And I can open up your arteries with an angioplasty balloon, or we could do it with broccoli. And I always ask people, what do you think is cheaper, or what do you think is costs less, and which one do you think works more, and which one do you think lasts longer? Well, if we can get you to go on a plant-based diet, you probably don't need the angioplasty, and we know that that will not last forever if you have an angioplasty. So high-tech empowers the medical industrial complex and is extremely expensive. Low-tech empowers the patient and is inexpensive. Drugs and high-tech treatments often have negative side effects, whereas lifestyle or low-tech interventions often have positive side effects. High-tech makes a good living for its practitioners, whereas low-tech practitioners starve. And that's one of the big problems facing the healthcare system. But we're working on that. We're trying to, we're coming at it from various angles. So like any good parents, my wife and I performed an experiment on our children. In 1991, we decided to become vegan. And the two little girls were toddlers at the time. Nathaniel wasn't born yet, so Nathaniel's been vegan since before birth. So there they are. What's the question is, but did they survive? So stay tuned. I'll tell you that. I'll talk to you about that later. So the underlying dietary pattern that we teach with our 15-day whole food plant-based jumpstart is the Esselstyn compliant eating pattern, which has been demonstrated in peer-reviewed literature to arrest and reverse heart disease. I'm sure if you've been coming to these meetings, you know what I'm talking about. It also happens to be great for most other chronic conditions. And it's similar to the program that Ornish developed back in the late 80s and early 90s. And what is it? Well, a whole food plant-based diet basically is whole plants and allows some minimally processed food, like for condiments mainly, we really avoid processed foods, and we avoid heavily processed food and oil, and of course we avoid all animal products. But this is the diet that we teach during the Jumpstart, which is a very low-fat whole food plant-based diet, or VLF-WF-PBD. Whole plants and some. Whoops, let me just go back here. Some nuts and minimally processed food we allow some, but basically we avoid most high-fat plant foods, including nuts, seeds, avocado, coconut, and olives. Actually, that's a little confusing. I think there's a mistake on this slide. It shouldn't say allow some, because we don't. We basically, the only high-fat plant food we encourage people to have is a tablespoon of ground flaxseed. Now that's just for the 2 weeks of the Jumpstart, and there we go. Okay. And after the Jumpstart, we ask people to consider moving back into a high-fat, utilizing high-fat plant foods. I'm not sure why my slides are advancing. Something's going on here. Anyway, the Esselstyn program for treating heart disease, what is it? Basically, it's what I just told you about. It's the very low fat, whole food plant-based diet. Who is Dr. Esselstyn? He's a surgeon at the Cleveland Clinic, retired after 35 years, former president of the American Association of Endocrine Surgeons, 1956 Olympic gold medalist in a very exciting race in Melbourne, Australia. He was rowing for the Yale team. He got a Bronze Star in Vietnam and received as an Army surgeon. Really amazing guy. 2005 received the first Benjamin Spock Award for compassion in medicine. And what is that plan? Well, foods to include vegetables, lots of greens, legumes, whole grains, fruit, but no nuts or oil. And people say, what about the healthy oils? What about olive oil or canola oil? And if you ask Dr. Esselstyn that, he'll say, no oil. In fact, if you Google no oil, that you're likely to get a video of him saying no oil. Again, foods to avoid: anything with a face or a mother, meat, poultry, fish, and eggs, dairy products, all oils, again, including the healthy oil, so-called healthy oils, refined grains, so white flour, white rice, etc., and really avoiding nuts, including coconut and avocado. Little asterisk there that some nuts are probably beneficial for most people, although we really don't recommend coconut because it's so high in saturated fat. But generally speaking, most people can tolerate some nuts, and it may actually be a positive thing. And we can talk about that later if we have time. Also avoid all processed foods and foods with added sugars. There's Dr. Esselstyn at one of the meetings in the American College of Lifestyle Medicine. You can see he's a pretty popular guy. He's got his groupies there. This is at our annual conference a few years ago. Now, I don't know how much you've reviewed about these this topic in the past, but these are slides I borrowed from Dr. Esselstyn. And the image on the left, where it says normal lumen, is a transverse image of a coronary artery, and it's completely normal. So the little black line here in the middle, or around the white part, is the endothelium. This is a muscular layer, and then this is the outer layer of the artery. This is normal. This is a very abnormal artery over here. There's a little tiny lumen in here. Now, this would probably show up as positive on a coronary artery scan. There probably would be calcifications there, and it would contribute to the score. In angiography, we would see something what we call the string sign. I'm not a cardiologist. I'm an interventional radiologist. So this type of artery is the kind of thing I might see in a carotid artery. And then we talk about the string sign there, where it's just a little tiny bit of blood flow that's going through there. Now, this is the type of plaque that causes sudden death. Let me go back for a second. So this is the type of plaque that causes angina. And what is angina? Angina is something where you feel fine at rest, but when you exercise or you walk to the mailbox or go up the stairs, you start to have chest pain. You sit down, you rest, you feel fine. If that's in your leg, you end up with something called claudication. You have to stop walking because you're feeling the pain in your leg because you're not getting enough blood flow out there, down there. So you sit down, your leg feels better, and then you can continue walking again for a certain distance. Now that's, if this is in the coronary artery, it's not likely to cause sudden death. This is the kind of plaque that is likely to cause sudden death. This would be a soft plaque, and I came in when you guys were discussing that. This plaque would almost certainly not show up on a coronary artery scan. It probably wouldn't even show up on a stress test because it's not causing enough narrowing to restrict flow to the point where it would cause symptoms. The problem with this kind of a plaque is that it can be unstable. Think of it as a pimple under the wall of the artery, right under that thin layer of endothelium, that gossamer thin single cell layer. And this is showing that where it's just got a little crack in it. Now, why would it crack like that? Well, maybe an extra fatty meal, maybe a little stress, maybe some exercise that maybe you couldn't tolerate. So this is a little bit of a rupture. It's got a little crack there, but once that starts, a little clot forms, and then that gets spread out a little bit, kind of a windsock effect as the blood is flowing down this direction. It rips that piece off the top of that plaque, and then it extends across the artery. And now there's complete blockage of flow to the myocardium, the muscle cell of the heart that's being serviced by that artery. And that muscle either dies or at least creates an arrhythmia. So you can have some kind of a fatal arrhythmia. And that's usually what causes sudden death in somebody with this kind of an issue. Now, the difference between these two plaques is that this one has taken decades to form. It didn't happen overnight. And so the person has been able to develop collateral arteries around the blockage. So collateral arteries, meaning it's basically their own little internal bypasses. So when this lumen gets completely blocked, which could happen, it may be a complete non-event. The person may not experience anything because they've developed enough collaterals around that so that it's the heart continues to receive enough blood flow. However, this has really not caused any significant ischemia over time. And so the patient has not developed collaterals around that potential blockage. And then when it becomes completely blocked, then there's no way for blood to get distally. And so that's when they end up with a heart attack. This is just a diagram. Dr. Esselstyn loves to talk about endothelial cells, and this is just a good example of what they look like. And he talks about eating lots and lots of greens, eating greens 6 times a day, before and after every meal, just to really bathe those endothelial cells in really health-giving antioxidants and all the other good things that are in greens. This is, anybody know what this is? So this is a normal abdominal aorta that's obviously been taken from someone who didn't make it. And you can see that nice glistening surface. That's what an endothelium should look like. And this has been cut open the long way. And you can see all those little dots there. That's where the branches are going to the lumbar arteries. Probably the thoracic arteries. And then down here are the lumbar arteries. This is the celiac axis, superior mesenteric artery, and then inferior mesenteric artery, and then some other branches down here into the pelvis. This is the same type of artery, the abdominal aorta, that has had decades and decades of the standard American diet or something else that causes atherosclerosis. And I ask people what this looks like. They usually say it looks like cheese pizza. And yeah, they usually say, yeah, it's probably from eating too much cheese pizza and hamburgers and bacon and all the things that Americans love to eat. So I ask people, what if this stuff were growing on your face? Would you leave it? Would you let it grow there for decades? Probably not. You'd probably be in the doctor's office tomorrow if you saw even a hint of that. But this is not growing on your face. It's on the inside. It's insidious. You don't even know about it. So it just sits there and keeps on growing. And again, this is what a normal endothelium looks like, nice shiny layer. And here it is compared to the abnormal, very atherosclerotic hardened artery. This is a story that Dr. Esselstyn likes to tell. This is Dr. Joe Crow, who was 44 at the time of this story. Many of you may have heard this story. He was a surgeon at the Cleveland Clinic who succeeded Dr. Esselstyn as chairman of the breast cancer task force. It was Friday in November 1996. I had operated all day. I finished, said goodbye to my last patient, and got a very bad headache. It hit me in a flash. I had to sit down. A minute or two after that, the chest pain started. It radiated up my arm and shoulder and into my jaw. So what was happening? Right. He's having a heart attack. But where is he? He's at the Cleveland Clinic. What better place to have a heart attack? That's where they really know how to take care of hearts. Somehow they got him into the coronary, a cath lab. They did a coronary angiogram. I don't know if they took him to the ER first. He was already in the building, but that's part of the story. I don't know. But they found out that this problem was inoperable and that a stent was not feasible. Now, is that good news or bad news? Well, actually, I think that's good news. For one thing, he survived the event, so that's the most important thing. But they didn't do anything. He doesn't have any hardware in there. He didn't have a bypass. 2 weeks later, he and his wife went to the Esselstyn's house for dinner. And they immediately embarked on the Esselstyn plan. And his total cholesterol dropped from 156 to 89. And his LDL went from 98 to 38. So according to Dr. Esselstyn, this gentleman would be heart attack proof. Because if you get your total cholesterol under 150 and your LDL under 80, Dr. Esselstyn considers you to be heart attack proof. That comes from the Framingham Heart Study in Massachusetts. And here's a picture of what the artery looked like at the time of the event. So his distal left anterior descending artery has got that really irregular, ratty looking portion. That's known as the widowmaker. How did it look almost 3 years later? Basically completely normal. So how does that happen? How do arteries heal like that? Well, it turns out the plaque is not made out of concrete, which is what I thought when I was in medical school. I didn't think they were going anywhere. The drug companies will tell you that. They'll tell you that if you take a statin or one of their other lipid-lowering drugs, that you can get improvement like that. But it turns out you can do that just as well with food, if not better, with none of the side effects and only good side effects. So how fast does the Esselstyn diet work? Well, that's a good question. We don't want to go around doing angiograms all the time. They're kind of invasive and expensive, and they can cause their own complications. So, but there is a test we can do that's non-invasive. So this would be cardiac PET scans. And if you look at the one on the right that says after RX, that's basically a normal left ventricle. And if you go 3 weeks earlier, this is a left ventricle where there's almost no, well, basically no blood flow going to the apex of the heart. And that's after exercise. So three weeks later, it's basically normal. So it happens really quickly that you can get these results. Here's one that shows lateral wall ischemia, and 12 weeks later, basically normal. This is medial and inferior wall ischemia. Got a cardiologist watching this, so if I get it wrong, he'll probably pipe in. This is a little bit of septal ischemia, lateral wall as well, and almost completely normal after 3 weeks. So jumping into what is the program that we've developed, it's called the 15-day Whole Food Plant-Based Jumpstart program, which we regard as the prescription for chronic disease. And it is based on the Esselstyn plan, which is a way of eating that can prevent, treat, and reverse heart disease, diabetes, obesity, and most of the chronic conditions causing so much misery in the industrial world. So how does our program work? Oh, and by the way, we are certified by the American College of Lifestyle Medicine. There's only a handful of programs that have received that certification. We are one of them. It's either four or five, depending on how you count them. And we've had almost 2,000 participants from 44 states and 9 countries since we launched in 2018. In 2020, because of the pandemic, we stopped doing it in our office and went completely virtual. So now we run it with somewhere between 40 and 60 people every month. And we just added another country. I understand that there's somebody from Egypt who just signed up for the August program. It's going to be kind of late at night for them. But anyway, other conditions that often improve and even resolve with a whole food plant-based diet: metabolic syndrome. And what is metabolic syndrome? It's obesity, hypercholesterolemia, hypertension, type 2 diabetes, which is something that occurs with insulin resistance. Peripheral neuropathy can actually get better, that you often see with diabetes. Retinal disease, heart disease is part of the metabolic syndrome, and fatty liver. So once again, what about our program? It follows the Esselstyn plan, which is a very low-fat, whole food plant-based diet, or VLF, WF, PBD. No oil, which is common to all whole food plant-based diets. So just something to remember, that even if you're not going on the very low-fat Esselstyn type diet, we still don't recommend any kind of oil. Have your high-fat plant foods in the whole form, so nuts, olives, seeds. And again, no high-fat plant foods. After the 2 weeks of the Jumpstart, we do talk to people about adding high-fat plant foods back in, but we also want to make sure that they have their labs drawn first, because they can often get very dramatic changes in their lab numbers while they're on this diet. And we want them to know what their body is capable of before they start adding back in high-fat plant foods. And some people may stay on this diet forever, and a lot of Dr. Esselstyn's patients have. So here's an example of a 61-year-old male patient presented in September 2018 with a hemoglobin A1C of 13.6 and not on any medication. So for those of you who have diabetes or know somebody with diabetes or know something about it, a hemoglobin A1C of 13.6 is very, very high. It should be, normal is under 5.5, and anything over 6.0 is considered diabetes. So his doctors were all basically saying, you got to go on medication. They ordered the medications for him. They were actually at the pharmacy, but he didn't pick them up. He said, I want to try this diet first. So hemoglobin A1C means his average blood sugar was around 350 for the preceding 3 months. And, blood sugar should be under 100. So he enrolled in our September Jumpstart, and he began the very low-fat, whole food plant-based diet. And by December, his hemoglobin A1C was 6.0, still no medication. By July 2019, his hemoglobin A1C was 5.4, and he had lost 70 pounds. So he doesn't have diabetes anymore. If he went to the doctor's office, they said they would have no way of knowing that he ever had, an episode of diabetes, basically. We ran into him in the summer of 2020. He's still doing well, and his wife's dress size had dropped from 22 to 14. So this ripple effect that goes out to family, friends, the community. When people start to do this, it has a positive effect on others that you may not even recognize. So I do check in with his doctor on a regular basis, and as of this spring, he's still doing fine, and very, very grateful. He sends us greeting cards around the holidays. Another example of a dramatic cholesterol drop. Anybody have any guesses about what's the most your cholesterol can drop in 2 weeks? 10 points, 20 points, 30 points maybe. So this was a woman who came in 50 years old, chronic kidney disease, total cholesterol of 299 at baseline. By day 15, her total cholesterol was 149. It dropped 150 points in 2 weeks. And we've had several people actually drop more than 200 points. And now they started even higher than 299. They were in the 400 or 500 range for total cholesterol, which is pretty unusual, but also, can be fairly dangerous. So it's great to see that kind of a drop that quickly. Most doctors are not aware of that can happen. And so it's one of the reasons that we really encourage people to talk to their doctors about these programs and actually enroll to kind of educate their own doctor. So we do have had a couple of patients exceed a 200-point drop. These are two doctors from the Rochester, New York area that happen to be married to each other. He's a local ER doctor. He got kicked upstairs. He's now president of a couple of hospitals or administrator of a couple of hospitals. And his wife is a local pediatrician. And they wanted to be experimental subjects. So they went on the 15-day Whole Food Plant-Based Jumpstart. They got their labs a day early on day 14. And the reason they did that is because Dustin wanted to present his numbers at a dinner he was sponsoring for hospital administration and sort of a business organization in the Rochester area. And he wanted to have a big reveal. And he wanted to show how much his cholesterol could drop in 2 weeks. And so I said, well, what if it doesn't work? Why would you, you're kind of taking a chance here. They're expecting that these incredible results. What if it doesn't? What if you don't follow my instructions, et cetera, et cetera? Anyway, so he followed my instructions. They both did. And Julie actually started out with a total cholesterol of 148. You see that on the top chart there. So 148 and LDL of 71. So according to Dr. Esselstyn, she was already heart attack proof with total cholesterol less than 150 and LDL under 80. So how did she do after 14 days? Well, her total cholesterol dropped to 112 and her LDL dropped to 46. So she got even better. How did Dustin do? Well, his total cholesterol went from 187 to 139, and his LDL dropped down to 83 from 126, all in 14 days. And so I said, I think you're heart attack proof. 80 is kind of an arbitrary number anyway. I think you did it. And he comes from a family of with a very strong family history. His father and grandfather both keeled over from heart attacks in their 50s, early 50s. And so he was really gratified by this and has become a fan. So what is the typical schedule for one of our jump starts? So when we first started this, the reason we chose 15 days for our jump start is because it begins and ends on the same day of the week. So we did it 3 Saturdays, and it was back when we had an office-based practice, and we could do the finger sticks on everybody when they came in on day number 1, and then on day 15 we would do the finger sticks again. And that's actually how we were able to reliably collect data to publish, which is how we ended up getting certified. So we had almost 400 patients go through the program before the pandemic hit and before we had to switch to Zoom. So now it's all on Zoom. And just to kind of, if you kind of go up here at the beginning of the yellow, so this is the first week of the Jumpstart, and we consider day 1 to be that first Saturday. But we have a day -3, which we now refer to as orientation, but that's kind of a check-in. Now we started doing that when we switched to Zoom, because back when we did this in March 2020, people were not that familiar with Zoom, and so we wanted to make sure that their connections were good and there weren't going to be any issues around that. But of course, everybody's now a Zoom expert, or a lot of people are. But we still like to have this orientation day because it allows people to be really ready on day 1 to kind of hit the ground running. They've got done their shopping, they've got their recipes and their menus all set to go. So day -3, we have a check-in for an hour. This is all Eastern time. On day, you can see there on the Friday, we asked them to get their labs drawn. And then day 1, we all get together for a 2-hour session. Then day number 12, which is, day 2 over here, which is on the 12th or whatever month this is, we have a cooking class. And then a day 5 check-in, which is for an hour on Wednesday. And then day 8 is a virtual potluck. Now, when we first started doing this program, we did the virtual we had a real potluck in our office. And one of the things we noted is that we had a pretty long time to clean up our office. It was a couple of hours after 24 people left behind their food crumbs and everything. Now, when we do a virtual potluck, we just hang out. There's no cleanup. It's really nice. And then, so then we get together again on day 12 For another 1 hour check-in, we often break into small groups. If it's a large group to start with, break into small groups of 8 or 10, 12 people. And everybody kind of talks about how things are going, successes, obstacles, that type of thing. And then day 15 is our commencement, and it's done. Now, a number of people will get their labs drawn on the final Friday here, so they can share it on day 15. But we don't expect that. We expect people to get their labs drawn maybe day 15 or 16 or even 17 the next week. And we usually will meet again with that same group the following Wednesday, which we call the first day of our alumni program. So we do have an alumni program to support people afterwards, because obviously 2 weeks is a great way to get started, but it's, this is something you got to do for a lifetime if you want to reap the benefits. So we also use something called the Google Classroom, because we like to be able to interact with people in between the meetings. So the Google Classroom is open 24 hours a day, and it's we post videos in there and other learning materials for participants, and they can communicate with each other on the Google Stream, which is like being on Facebook, but it's not Facebook. A lot of people won't do Facebook anymore. We used to use Facebook groups, but our experience when we first started was about a quarter to a third of people wouldn't go on Facebook, and now it's more like a half of people won't go on Facebook, and I don't blame them. So we use the Google Classroom, and this is an example of what the RLMI Jumpstart for 2021 looked like. You can see that's my wife who's greeting everybody there, and that's called the stream. And then this is the classwork. You can see over here we've got topics on the side, and then these topics will appear as we progress in time through the 2 weeks. And you can see there's assignments down here for people to read the Jumpstart package, also to fill out their surveys. We do try to track a lot of data if we can, so we can continue to publish. And we have published a number of times, and I'll show you some of those citations. So this would be an example of some topics that get covered in the Google Classroom. It's very handy, very easy to use. And then you can click on the people, and you can see those are the teachers. Our daughter, Rebecca Barnett, was one of the teachers for that particular class. She's a music teacher at a Quaker school in Brooklyn, and she's the one who introduced us to the Google Classroom. Said, Dad, you got to try the Google Classroom. And luckily that was back in March 2020. And we were able to very quickly pivot to going completely virtual. It's actually been lovely, because we've been able to meet people from all over the country and all over the world. So the virtual potluck, I just want to show you what that looks like. Patients send us recipes and photos, and then we create a PDF that we call the virtual cookbook. And then we show that off during the virtual potluck, and people are called on to discuss their recipes and their cooking experience. So this is a beautiful example of a roasted vegetable salad. Another beautiful example of just roasted vegetables. People get very artistic. This person made some beautiful entree and a beautiful dessert. And the beautiful dessert is actually whole food plant-based. It's just frozen bananas, vanilla, and frozen raspberries. What kind of results do we get? Starting from left to right there, on average, people lose about 6 pounds. For people whose BMI is in the obese range, greater than 30, they lose about 7 pounds in 2 weeks. Systolic blood pressure drops about 7 points on average, and almost 17 points if your blood pressure is over 140. Total cholesterol, the group as a whole tends to drop around 26 points on average. If your cholesterol is over 200, you'll see a drop of 44. And if it's over 240, you'll see a drop on average of 64 points. LDL, similar drops can be more than 33 points if your LDL is over 100 when you start. Glucose tends to improve, and if you're in the diabetes range, you can expect a drop of about 28 points on your glucose. This is a group of people on the Jumpstart, and I just remembered I want to share a video with you, so I have to stop sharing for a minute because I didn't click the share sound button. But luckily, I just remembered, and here we go. Here we go. Hi, I'm Dr. Ted Barnett, founding president of Rochester Lifestyle Medicine Institute. It's so great to be here, and I'd like to introduce you to some recent graduates to tell you about the Jumpstart program.
Hi, I'm Kathy. I Jumpstarted to improve my health.
Hi, I'm Beth. I jump-started to improve my health.
Hi, I'm Wendy, and I jump-started to reduce my pain from lupus.
Hi, I'm Pamela. I reduced my meds and I'm saving money.
Hi there, everyone. Since starting Jumpstart, my energy is so much higher.
And I have more energy too.
Hi, I'm Ruth Ann. I jump-started and I'm sleeping much better.
I'm waking up more refreshed.
I'm happier more often now.
And I am feeling so much better in how I look, how I feel, positive attitude. Life just feels great.
I wake up well rested and I get out of bed without pain.
Hi, I'm Jamie. I lost 19 pounds in just 2 weeks by eating a plant-based diet.
I lost 12 pounds in just 2 weeks by eating plant-based diet.
I lost 16 pounds in just 2 weeks by eating a plant-based diet.
I lost 11 pounds in just 2 weeks from eating a plant-based diet.
And I lowered my blood pressure 25 points and I feel great.
I lowered my cholesterol 100 points, and now I am heart attack proof.
I lowered my glucose by 86 points, and I'm no longer pre-diabetic.
I reduced my meds, and I'm saving money too.
Hi, I'm Neil. I've eliminated 4 meds, which I've been taking for 30 years. My cardiologist knew that a plant-based diet works. I stuck to the Jumpstart diet, and it worked.
I wake up well rested and get out of bed without pain.
I thought that changing my diet would be difficult, but it wasn't, and I've been doing it.
I jump-started my health, and so can you.
Hi, I'm Bob Franke. I manage the Jumpstart team, and I'm here to help you succeed.
Hi, I'm Kim, and I'm on the Jumpstart team, and we'll support you all along the Jumpstart journey.
Hi, I'm Bubby. I'm on the Jumpstart team too, and will help you overcome any obstacles on your road to better health.
Jumpstart has changed my life, and I'm pain-free.
Jumpstart has changed my life. Jumpstart has saved my life.
Want to improve your health and well-being?
Want to sleep better?
Do you want to have less pain?
And feeling happier more often?
So sign up today and start your journey on the path toward better health. I look forward to seeing you there. We can do this together. Oh, I just did that. There we go. So yeah, we put that together a few months ago, and it's just so gratifying to see all those testimonials. So some people will say, but isn't this diet experimental? How can you do this to people? And how do we even know if it's safe? So I ask you, which of these diets is experimental? This one, the standard American diet? Or this one that looks like food that our ancestors would recognize quite readily? So if what you are telling me is true, why don't I already know this? And why isn't this common medical practice? Hint, follow the money into politics. And this is the subject of another discussion, which we don't have time for tonight, but it's really quite amazing to me. So what is lifestyle medicine? Chris Burkett of Burkett's Lymphoma and Dietary Fiber fame says, Western doctors are like poor plumbers. They treat an overflowing sink by cleaning up the water. These plumbers are extremely apt at drying up the water, constantly inventing new, expensive, and refined methods of drying up water. Somebody should teach them how to close the tap. So closing the tap with lifestyle medicine. I've already shown you our nine-spoke wellness wheel. Lifestyle medicine addresses the causes rather than the symptoms of disease. There are 6 official ACLM pillars, which we went over before: whole food plant-based diet, physical activity, avoidance of toxins, restorative sleep, managing stress, and fostering positive relationships. And then we've added 3 more, as I mentioned before: enjoying nature, seeking purpose, and finding joy. So when I joined the American College of Lifestyle Medicine in 2010, we had 132 members. If you look over there on the left side, we now have about 11,000 members, and it's growing remarkably quickly. It's basically the fastest growing specialty in the medical world. And it's a similar plot, though, unfortunately, to how many people are living on the planet. And this is why we have a sense of urgency. We're going to end up with 10 billion people before we max out, probably. We're at about over 7 billion now. And the environmental consequences of eating animal products are quite dramatic. So this is something from the Plantrition Project showing how many acres of land it takes to feed an American on the standard American diet, or a person on the standard American diet. It takes about 2 football fields. That same amount of land could feed 14 people per year on a plant-based diet. And if everyone in the world ate plant-based, 5 billion football fields worth of land could be returned to forests. And think about what's happening in the Amazon forest, which is being cleared basically now to grow animals, for feed crops for animals and for grazing. And we need the Amazon rainforest for other reasons to help fight off climate change. Hey, how did that experiment on your children turn out? Remember I told you about our kids? Well, here they are in 1990, before Nathaniel was born. We went vegan in 1991. All plant-powered in 2003. Here we are in the Galapagos Islands. Everybody there is on a plant-based diet, including the Galapagos tortoise. And here we are crossing the Panama Canal. My wife doesn't like to travel. She gets a break when I take off with the kids. And here we are in 2005 at a wedding, and you can see Nathaniel's in the middle, and everyone says, he's such a shrimp. He's never going to grow. You got to feed him meat. And then a few years later, he's towering over everybody. We're still all plant-based after all these years. Nathaniel runs a couple of nonprofits, and one of which is the Uncommon Music Festival in Alaska. And we're going to hear more about him in a minute. Here they are, various times. These are all kids who've never had animal products. Well, I mean, except by accident. There's my beautiful wife, daughter, another son, Becca, Elizabeth, and Nate. I like to show off my kids just so you'll know that people can raise families this way. It actually works. If anybody's from New York State, you're probably not. You're all from Wisconsin. So this is the day I became a 46er, meaning I climbed all 46 high peaks in the Adirondacks. You can see Nathaniel's holding a bottle of champagne there. He already had his 46er. And we climbed up in quite a rainy day. And Elizabeth, I had to Photoshop her in. She would never have climbed that mountain in the rain. So we didn't even try. Here we are out in Zion National Park, just having climbed up from that valley, all on plants. Here we are in Alaska, where we visited Nate. And photobombing, still healthy after all these years. And our youngest Nathaniel is now 31, actually just got a Grammy. So he got 1/24th of a Grammy, actually. He's in a professional choir, and their last album received the Grammy Award. So there was 24 people in the choir. So I guess he gets a 24th of that. If you're interested, we can get you posters. This is an attempt at humor. This is a spoof on drug ads. Instead of asking your doctor if a particular medication is good for you, ask your doctor if eating a healthy diet is right for you. And side effects may include losing weight without counting calories. Now, that's one thing about this program. No counting calories and no worrying about portion size. Reversing type 2 diabetes, lowering cholesterol and blood pressure, reversing heart disease. You have less inflammation and pain, less gastroesophageal reflux disease, constipation and irritable bowel, improved erectile function and fewer hot flashes, decreased medication and lower drug costs, more energy, improved sleep, better mood. And the reduced pain is amazing to me, because I can't tell you how many people come to us because they want to get their cholesterol down. And actually, which happens, but after a week or so, they say, you know, I didn't even realize I had arthritis. But now I wake up in the morning, I'm jumping out of bed, I'm not stiff anymore. So how much does it really cost to eat healthy like this? Basically nothing. People have to buy food anyway. And this food is not any more expensive than the standard American diet, if you do it right. So we have created the Jumpstart program to have a low barrier to entry for doctors and patients. We make it enticing to patients. We can say, look, you're a grown-up, you can do anything for 2 weeks. There's a rapid demonstration of value. It's fun and supportive. We all get together on these little Zoom screens. It's great. It's affordable. The price is actually $299. And if you get a referral from your doctor, the price is $199. And if you sign up for the $2.99 and you get a referral later, we give you $100 back. Now, why do we do that? Well, we're a nonprofit with a mission of changing the healthcare system, and we want your doctors to know about this. That's why we do it that way. We've given it over 60 times now to about 2,000 people as of July of this year. It's easy for physicians to order, and I'll show you that in a minute. We really want to make it easy for doctors to be able to get this for their patients. And over 200 doctors around the country refer patients to us. And we like this program because it counteracts misinformation and disinformation. People say, well, gee, what about keto? What about paleo? How do I know you're telling me the truth? And we say, look, maybe we're not telling you the truth, but in 2 weeks, you're going to find out. And that's a great, in my opinion, is a great way to counter misinformation and disinformation. People are experts on their own bodies. It's also reproducible for research and demonstrations. It's a standardized research tool. I think of it as like pouring pills out of a bottle. So why is it that only pharmaceutical companies can have randomized controlled trials that are actually double blind, right? Where they can, people can tell when they're, people can tell when they're getting plastic broccoli. They can't tell when they're getting the placebo in the control group of a pill trial. But obviously we can't do that. We can't do a blinded study, but we can do randomized trials. And we just did complete a randomized control trial with the nephrology department at the University of Rochester. So studies that we've completed, as I mentioned, the randomized control trial with the nephrology department. These are 40 patients with stage 3 and 4 CKD. It's been accepted for publication. They're just working on it now. We've also had abstracts accepted at the annual conference of the American Society of Nephrology. In progress, we're working with the rheumatology department at the University of Rochester, a randomized control trial on psoriatic arthritis. And then we're also planning on a trial at the RIT, a large trial with employees, and more about that. I'm going to just skip through this because I know we want to get the Q&A, but we have published a number of times. And if you make a video of this, people can watch this on the video and stop it to see what's going on there. We've had a number of conference posters at American College of Lifestyle Medicine. Dr. Susan Friedman is our director of clinical studies. She's a professor of geriatrics at the University of Rochester, and she loves to publish, and she gets a lot of our stuff created, and we win a fair number of awards for our posters. Very excited about that. And I'm going to just go real quickly. If you're a doctor or you know a doctor who you think would be interested in this, they go right to the homepage of rochesterlifestylemedicine.org, and they click on that for medical professionals. And they click on that, and it takes them to a page like this that says online provider or patient referral form. They click on that, and it takes them right to a Google form. And the Google form, the provider gives their name, and then they type in their own email. We get their phone number, and then they type in the patient's information, or they have their assistant do it. So it's all we need is a name and a phone number, and then our staff contacts the patient and gets them enrolled in the program. And it's not just a Jumpstart; we offer a couple of other Zoom-based programs. So we like to think of ourselves as operationalizing plant-based nutrition in a broken healthcare system. The Jumpstart program easily scales and reaches everywhere, and it's simple for doctors to order. So how can you help us change the healthcare system, save human and animal lives, and heal the planet? Well, recommend potential participants to come to our free information sessions. Every month we run a free information session about Jumpstart. And you can invite doctors to our free CME programs. And in fact, if a doctor goes through Jumpstart, not only is it free for them, but they also receive 10 CMEs actually for attending our Jumpstart in person, because it's certified through the Rochester Academy of Medicine for CME. And then, of course, we are always looking for donors. And if you're interested in helping us, we're not embarrassed to make shameless plugs. Like I said, I'm a volunteer, as is my wife. So nothing of any real positive social value has ever been achieved from the top down. It's always been achieved from the bottom up. And Howard Zinn said that in his book, A People's History of the United States. And thank you very much. And I'm going to stop sharing. And I look forward to answering your questions. So Terry, how did I do?
You did very well. You did
All right.
very well. And just to put a little cap on it, we have, most of our meetings have been talking about why plant-based nutrition makes a lot of sense. We've spent very little time on how to do it. And that's why we had Dr. Barnett here today. This is a perfect way to to have somebody who knows what they're doing, a number of people who know what they're doing, lead you lead you down the path. People who go fishing sometimes get a tour. Get a guide, a fishing guide. This is the fishing guide for whole food plant-based nutrition, and what a great program to have with all the experience you've already had, with the results that you've already had. This is just outstanding for physicians as well as for individuals. I know that in the chat we had a number of people pop things in here, and I don't know if you can see it, but the first one is from Michael. You see the first one from Michael?
Let's see. Michael says, if you do the Jumpstart program and continue with the diet, but then fall off the wagon and have an avocado or pastrami sandwich, do you have to restart with the Jumpstart 2-week program or just continue a plant-based diet? Well, that's an interesting question. So first of all, falling off the wagon with avocado and pastrami, those are different sides of a wagon, I would say. Avocado is actually pretty healthy, in fact, extremely healthy. Pastrami is a bit of a problem, but no, you wouldn't have to restart it. You can go on a whole food plant-based diet any way you want. It doesn't have to be all at once. Our approach is to do it all at once because we think it's a way to attract a lot of people and have them quickly find out whether it's something they want to do. The problem with doing slow incremental programs is that you don't see a lot of improvement either in your numbers or in the way you feel very quickly. And so it just becomes kind of irritating because you're just sort of partway there. And I think it's easier for people to fall off the sort of wander off. We don't use wagon. We say wander off the path. But anyway, but obviously, however you get there, after a year of being on a whole food plant-based diet, I don't think it matters whether you did the Jumpstart or not. The question is how to make it successful. And honestly, when you think about research, I don't think we really need to be doing research anymore on whether the diet works. I'm actually getting kind of tired of that. We know the diet works. The research needs to be done on how to get people to start it and stick with it. That's where the real challenge is. If they do it, it almost always works. In fact, we can tell when people have not really followed the instructions if their labs don't get better. So the answer to that is no, you wouldn't have to do the Jumpstart again. We do have people who do take the Jumpstart over and over, though. We've had people do it 3 or 4 times just because they like the camaraderie and they feel like they can't really do it without the support. But we also have an alumni program, which is free, that we meet once a month with people. There's about 400 people in that. So yeah, what's next?
On the tech side, can you recommend an app, an iPhone that can track my low and high FODMAP selections for my plant-based eating plan?
Interesting. So we use an app called, we use a couple of different apps. I'm not a huge fan of apps. I don't think you need them, but if you're trying to track something, we use Chronometer, which is spelled, it's spelled wrong. It's spelled without the H. So it's Chronometer, CRONOMETER. We actually have a version that if you want, we can let you use the professional version of it, but you can set it up on your own. It has both a phone app and a web application, and you can put in the foods that you want to know about in terms of macronutrients and micronutrients. It'll tell you what you're getting. I'm not exactly sure how you would use that for the FODMAP diet, so I think I would Google that one. The other program we use is called EAT, which is kind of ridiculous, kind of a silly name. Is it called EAT? It's called, I think it used to be 2 words and then they got it down to 1 word. But anyway, that one you just take pictures of your food, and it's to see whether you're on the right track or not. I think I might have the name wrong there, but we use 2, and I would Google that question about low FODMAP diets. So yeah, what's next?
Next one is from Julie. So does height have to do with genetics? It seems all my nephews are tall, standard diet, and my grandson, who's 14 plant-based since birth, is still under 5 feet.
Well, that's interesting. There's 2 questions here. Well, yes, height is height is totally determined by your genetics, basically. If you've got short genes, it doesn't really matter what you're going to eat. Now, it is true on the standard American diet, I think kids tend to grow a little faster early on, and they tend to reach puberty earlier. So growing tall and, and growing large and quickly is what you want from your farm animals, right? I mean, I don't want that from my farm animals, but that's what a farmer wants. So there's this assumption that, getting big and tall quickly means you're on a really good diet, but it may be that that's not true. What we want to do is avoid disease, right? And the standard American diet is associated with disease, heart disease, diabetes, obesity. So yeah, maybe you'll grow a little taller, maybe you'll grow a little quicker, but that may not really be your goal. And I noticed you mentioned your grandson is short, and your nephews are tall, so they don't exactly have the same genes. But at the age of 14, if he hasn't hit puberty, he may still have time, may still be getting his growth spurt coming up. That happened to our son Nate. He was pretty short until he hit puberty, and then boom, he just shot up just like just like you'd expect.
Donna asks, should I stop my statin if I go on the Jumpstart diet?
Donna, please stay on your statin, and here's why. You want to not change anything during the Jumpstart. So if you're gonna, I wouldn't stop your statin anyway. It's unless you're not tolerating it. Unless first of all, don't do it unless your doctor says it's okay. But there's nothing dangerous about having a low cholesterol. So assuming you're tolerating your statin, just stay on the statin, and then at the end of 2 weeks, get your blood drawn at just before you start the Jumpstart. Get your blood drawn again after the Jumpstart and see how you did. If you stop your statin and during Jumpstart, your cholesterol is actually likely to go up, and you're going to think it didn't work. So stay with that. There are some medications we ask people to come off of, or at least talk to their doctor about. So high blood pressure medications and also blood sugar medications, because it is dangerous to have a low blood sugar, and it is dangerous to have low blood pressure. You could pass out, hit your head, and then we'd have all this paperwork. We don't want that. But there's nothing, you're not going to pass out if your cholesterol is really low. So stay on your statin if you're considering doing that.
I'll try to lightning round you here, because I think we have 7 or 8. We've only got about 3 minutes left here.
Right.
Michael says, I'm 66 years old, concerned about getting enough protein. I've been on a plant progressive diet. I eat dairy for many years. I see the atrophy in my muscles. Can you tell me the minimum amount of daily protein needed as we age? And can I get on? And can I get this on the Jumpstart diet?
Yeah, so absolutely, there's plenty of protein in all whole plants. Actually, it's it was a topic of conversation today at the conference. If you know Brenda Davis, if you're familiar with her work, I would Google, see if there's any YouTube videos that she's done recently. She talks a lot about protein now and basically says you don't need to worry about it. I would, as long as you're getting the minimum amount of protein, which is probably only 50 grams is what you're going to need, maybe 60, you're going to be fine. And this is a lightning round, so I can't go too much into protein, but maybe if we have time later. Keep going.
We got 2 of them here from 2 different Karens. Fabulous presentation, very impressive presentation. Ruth says, does the 15-day Jumpstart include fasting for any users?
When you say fasting, I'm assuming you're talking about intermittent fasting, which is really time-restricted eating. Obviously, if you're going to just be fasting, you don't need to do our program. But time-restricted eating, like you don't eat until breakfast at 8 o'clock, and maybe in the morning, maybe you stop eating by 4 in the afternoon, something like that. Some people do that. It's not part of the program, but a number of people do that, and that's fine. I'm assuming that was what the question was.
Barbara says, what is the website again?
So Rochester Lifestyle Medicine Institute. If you just Google that, we'll pop right up. I mean, the actual URL is rochesterlifestylemedicine.org.
Marlene says, do you think that lowering LDL too low is a risk for dementia?
No, I don't think that's an issue.
Sarah says, I am mostly plant-based, but I eat dairy and nuts in an attempt to get enough protein. What alternatives do you suggest?
Okay, so another protein question. So first of all, I am going to spend a little time on protein because that's another one about this. So how much protein do we need in our diet? We probably only need 10 to 15% of our calories to come from protein. Now, if you're getting empty calories, how much protein is in a can of Coke? 0, right? How much in a bag of potato chips? Maybe 5% of the calories from protein is a bag of potato chips. So you could be a junk food vegan and you could become protein deficient. However, if you drink water, which has no calories and no sugar, right? It's not empty calories because there's no calories, and you eat the potato, the white potato, but not the potato chips, that potato is 10% calories from protein. Is that in that range of 10 to 15%? Yes. What's the percent calories from protein in grains? 14, 15%. What about legumes? Around 25%. And what about vegetables? They're actually quite high in protein as a percentage of calories. So broccoli is 44% calories from protein. That's, plenty of protein. So you're going to get enough protein. We got to get over this whole idea. If you're eating enough food, getting enough calories, you will get enough protein. And again, if you want to, I can stick around a little longer if you want. We can talk about that later.
Marcia says where the labs get done is the cost part of the program or through our own insurance? I imagine for the labs is the cost of the labs.
So the cost is on you or your insurance company. Our program is not covered by insurance at this time. Since it is, think about it this way though, it's basically 7 visits with a healthcare professional because all of our programs are medically facilitated. If you had to pay copays on 7 visits and you were paying $40 in each copay, that would cost you $280, 7 times 40, right? So it would actually cost you more if you had your insurance if your insurance covered it, because you'd have all these copays. With a referral, it's $199. That's something we are working on, is trying to get it reimbursed. We are working with a few companies to get it on their benefits program, so the company will cover it. But you do have to figure out how to get the labs done. Now, if your doctor writes writes a prescription for your labs, it should be covered by insurance. It may not be, but it should be.
So, Dr. Barnett, something like the Orange program, it can be covered by insurance, but that's after you've had a heart attack. So this is trying to avoid having a heart attack in the first place.
Exactly.
It seems to be a good investment.
Right. And the Orange program is great, but it took them 16 years to get Medicare to pay for it.
That's right.
So,
and it works.
It does, yeah.
Marlene says, have you thought about doing group visits in your area and get reimbursement for all your hard work and come into the limelight for insurance companies?
So yeah, it's a great question. So I don't know, is Dr. Melina, are you a physician? Interesting, because we do work with doctors who want to do shared medical appointments. It is a way for lifestyle medicine doctors to get reimbursed.
Yes, she is.
Okay, I kind of figured. So we did, when we were running in our office, we did bill it as a shared medical appointment, and we were getting reimbursed by insurance companies, but it was just as a medical visit. Now that we're basically international, and we've actually closed our medical practice, so we don't have a medical practice anymore. We just do this because of the pandemic, and truthfully, it's a real benefit. We're reaching a lot more people this way, and we do work with a couple of with different physicians around the country. MedStar in Washington has a physician who runs shared medical appointments with us, and we can help advise people, doctors, on how to do that. Our experience, though, with shared medical appointments is that it's hard to run them because it's hard to get patients to show up at the same time. So trying to get 10 or 15 patients together, which is really what you need to make it worth your while, it can be pretty challenging. I mean, it can be worth your while with just 5 or 6 patients in the room at the same time. But again, yeah, we are working on that. If you want to talk to me about that offline, I'd be happy to.
In the last one here, Gloria, I've heard that low cholesterol can lead to depression.
Yeah, that's one of those misconceptions out there. I'm not sure where that came from. There are some chronic illnesses that will cause low cholesterol. So if you're, have cirrhosis of the liver and you're basically starving, you will have low cholesterol, but the cholesterol is a result of that. It's not a cause of that. So I don't think there's any really good evidence that having low cholesterol will lead to depression. I would not worry about that.
And I've got a last question, Doctor, and that's with the alumni group. So how once somebody's gone through the program and they want to continue to be successful, how long? The alumni group, you feel has worked in that respect. How long have some of these people been in the program at this point?
Oh, we've been doing it since 2018, so 5 years for some of them. We're really promoting we're working a lot harder on our alumni program now. We really had to, there's a lot to work on with this kind of a project, and so we really wanted to kind of perfect the Jumpstart itself as a tool to help operationalize lifestyle medicine. But we are working more on the alumni program now. it is free. Meets once a month. It's free. We're going to be adding more frequent visits, and there will probably be a charge for that at some point, but there will always be a free component that meets once a month.
So being a former accountant and a financial advisor, I would say if you took the 12 Jumpstart, it's 12 different appointments or whatever for the Jumpstart, 12 different.
7.
You should actually be spreading the value that you're receiving over all the free alumni programs as well.
That's right.
So the cost per visit, so to speak, drops dramatically.
Yeah. So Terry, I didn't realize you were a financial advisor. It's kind of funny. We had one of our graduates is in the state of Washington. His name is Neil, and he's a financial advisor. And he said, this program is worth $2 million to me. And we said, what? He said, yeah, it's worth $2 million because I'm expecting to live an extra 20 years and I make about $100,000 a year. So it's worth $2 million. It's like the best bargain ever. So I said, okay, great, we'll take it. And he was very sick. I mean, he was obese and had heart disease, and he really was getting his affairs in order. And he's in his, late 60s and doing great now.
Oh my goodness, that's a great story.
Yeah.
Well, thank you, Dr. Barnett. This was an outstanding presentation. And I guess I should ask another question. So if you're a relatively healthy person, do you have many relatively healthy people just joining the program as a way to kind of improve what they're already doing and to be in a community, and then to have this ongoing support that you provide?
Right. Yeah, absolutely. I mean, we love it when people are there to prevent disease. The problem is that most people aren't really interested in changing their lives or their lifestyle until they have some kind of an event.
Sure.
Right. And of course the earlier the better. And if there are any other medical people in the audience, I do encourage you to go to our lifestyle medicine grand rounds, which we run every month. I think it's the second Tuesday of every month. Take a look at our website. Where we present cases to a panel of lifestyle medicine experts. We usually have somebody famous every month, like Dr. McDougall or Dr. Barnard or Dr. Clapper, and with our panel of experts. And the interesting cases presented, we record the discussion, and we do post that on our website later on. So, and it's a free hour of CME. So, yeah, that was another plug.
What a great idea.
Yeah.
Well, thank you so much. And everybody here, our next monthly meeting will be Thursday, September 14th, when our featured speaker will be our PB Now Medical Director, cardiologist, Dr. Josh Lieberman. If you'd like to receive notice of this, just Google us at PB Now and hit the Learn More button to register, and you'll begin to receive notice of our upcoming events. If you'd like to check out our past meetings, just go to the video library section of our website, or just Google us at PB on YouTube. Go to YouTube under PB Now or pbnow.org. You can see our past meetings. Thanks again so much, Dr. Barnett, for spending your valuable time with us tonight. And also thank you, Dr. Josh or Dr. Lieberman, for the time you spent, your valuable time and knowledge with us tonight. Good night, and thanks, everybody.
Good night. Thank you.